and welcome to Ask the Doctor, the video series that highlights the wonderful work of newly graduated researchers and PhD candidates. My name is Matt Wirdnam and I'm a physiotherapist and graduate researcher here at Trobe University's Sport and Exercise Medicine Research Centre. Our guests on the first episode of Ask the Doctor are Dr. Danilo de Oliveria Silva and Dr. Christian Barton. Prior to completing his PhD, Dr. Silva completed a Bachelor of Physiotherapy with honours at the State University of Western Parana, followed by a Masters of Science at Sao Paulo State University. In 2019, Dr. Silva completed his PhD thesis on the nature of patellofemoral pain and the integration of biomechanical, clinical, and psychological factors. During his time as a PhD student, Danilo was supervised by Associate Professor Christian Barton, who has been kind enough to join us in today's discussion. For those of you who may be unfamiliar, Dr. Barton is a physiotherapist and world-leading researcher in the fields of patellofemoral pain and knee osteoarthritis. So, without further delay, Dr. Silva, Dr. Barton, welcome to the Ask the Doctor series.
Thank you.
Thanks for having us, Matt.
Danilo, historically, patellofemoral pain research has had a strong focus on biomechanics and sometimes has tried to establish links between the strength and movement patterns. Can you tell us how your PhD research differed from previous work completed in the patellofemoral pain space? And did your research confirm this link?
Sure, yes, no problems. Most of the research done in patellofemoral pain so far is on biomechanics. That's why we have a much better understanding of biomechanics than other aspects of the condition. So it's absolutely normal that we talk more about biomechanics. And actually, my research was firstly focused on biomechanics. I completed a master's by research, as you said, looking at joint kinetics and kinematics, differences between people with patellofemoral pain and pain-free controls. For my PhD, though, Christian got on board and helped me to shift my attention to other clinically important outcomes as well as biomechanics. So what we did was to bring together our expertise in biomechanics and explore how it interacts with psychological and clinical outcomes. I believe the novelty of this part of my PhD was to connect two areas that were being explored in patellofemoral pain, but in their own niches. So just in terms of results, what we found was that knee strength was not related with how a person with patellofemoral pain moves their knees. However, there is a strong relationship between how fearful they are and how they move their knees. More specifically, the higher their fear of movement is, the lower their knee flexion will be and the slower they will move. Therefore, we found that a psychological variable was strongly associated with a traditional biomechanical variable. And just to complete my answer, in a follow-up study, we looked at what variables would then have a stronger influence in the pain experience and disability of these patients. And we found that fear of movement had a much higher correlation with pain and disability than patellofemoral joint stress or contact forces. And altogether, these findings really indicate to us that we shouldn't look only at how our patients with patellofemoral pain are moving, but also to other factors that may be influencing their pain experience. And this includes psychological variables.
Wow, that's really interesting. Christian, how did this, or maybe I should say, did the results of Danilo's PhD research, did it surprise you?
I think initially it did surprise me because, as Danilo suggested, in the patellofemoral pain research field and probably musculoskeletal pain more broadly, we've had this long-standing focus on biomechanics and physical impairments in people. And they certainly do exist. So there are biomechanical differences and impairments whether it be strength, the way someone moves, joint stresses, that we can see differences in people with pain to people without. But what we probably haven't paid enough attention to over the years across the broader scope of musculoskeletal pain, and patellofemoral pain is a good example, is looking at psychological factors. And so with my clinical hat on, I expected that they would be related to things like pain and disability, and I expected them to play a role. I don't think I had a full grasp of the fact that they probably play a much bigger role when it comes to pain and disability than the biomechanical things that we focus on a lot more. So it's probably through Danilo's research has changed my clinical practice quite a bit over the past 5 or 6 years, which has been quite good. Not that I neglected psychological factors, but I probably focus more on the physical part in comparison to psychological, whereas I probably am shifting the other way these days with a lot of the patients I see, particularly for pain and disability. When it comes to performance, it's a different story. Maybe we can touch on that in a little bit.
Absolutely. Now, we all know how useful the internet can be and how easily information can be accessed, but not all the information on the internet is accurate or helpful for that matter. Danilo, if a patient with patellofemoral pain is unable to access a registered healthcare professional due to locality or their own personal circumstance, did your research suggest that web-based information can be effective at managing their condition?
That is a very good question. We have published a paper a couple of years ago showing that the general information about patellofemoral pain that you find on the internet is quite bad, actually. In many cases, the information is inaccurate and misleading. And this is one of the things that I love about working with Christian, because when we found that, he said that my PhD couldn't finish just criticizing something, but that we should finish in a positive way and offering people some solution. And this really motivated me to work harder on the website we were developing. minecap.trackeducation.org. We can share the link later in the description. This website provides education and an exercise program to people with patellofemoral pain. And the last study of my PhD was a pilot trial testing the feasibility of this website as an intervention. And we found that if our website is provided as a first-line treatment, 1 in 5 patients may be able to independently manage their own condition without the need for additional health professional referral. And 2 in 5 would be markedly better. So these are the findings from our pilot study. So answering your question directly, yes, I'm happy to recommend this website to people with patellofemoral pain, not others maybe.
Amazing. And Christian, do you have anything to add to that?
I think just to echo Danilo, that certainly the website that we have developed is very helpful for patients. Just to share an interesting story about a PH journey, which this is kind of about, is Danilo moved halfway across the world to join us at La Trobe, not to develop websites and resources, but actually to spend time in our amazing gait lab that we have at La Trobe University. And so I asked Danilo a question is, how much time did you spend in our gait lab during the PhD and what influenced that?
I think I didn't get into the lab in the first 6 months. Then I got there to know how it looked.
So to cut a long story short, Danilo, after being with us for a couple of months, completely changed tact of what he wanted to do. Not pushed by me, but just, I guess he sort of saw the value in what he'd learnt previously from his PhD and the psychological factors, and probably decided pretty quickly that doing further biomechanical research wasn't going to be able to influence them. And he come to me one day in our meeting and just said, the website we've been talking about, I want to focus on that for the rest of my PhD. So huge kudos to him, because without his change in his passion, so it wouldn't have happened, and without his preliminary research before that, the passions wouldn't have changed either. So he's done an amazing job with it.
Yeah, that's fantastic, and it's so great to hear the evolution of Danilo as a master's student and as a PhD student, and now as a postdoctoral research fellow. We have a question from Dr. Nat Collins, and she'd like to know, what are your tips for clinicians to assess and address the psychological factors in people with patellofemoral pain?
That's fantastic. It's actually an honor to get a question from Nat. She has made outstanding contributions to the patellofemoral pain field alongside Bill Vicenzido and Kay Crosley. So yeah, it's pretty good. So, okay, tips for clinicians. To assess psychological factors, we can use the same instruments that we use in research, and this would be a great way to track how patients progress. So things like the TEMPA scale for kinesiophobia to assess fear of movement, the NICE self-efficacy scale to assess self-efficacy, and many others, depending on the psychological factor you are interested on. But from a clinical point of view, and Christian can go on that better than me, I would say that understanding what tasks your patient is struggling to do and exposing them to these tasks to get a sense of what strategies you can use and at what extent this psychological barrier is present in the patient in front of you. For example, we published a randomized controlled trial 2 years ago showing that a simple knee brace could reduce the fear of movement of patients with patellofemoral pain. So a knee brace could be a good adjunct to promote exercise therapy and physical activity, interventions that we know that improve pain, physical function, and quality of life. So using the knee brace could be helpful in that sense. But I know Christian has great examples on how to tackle that in clinical practice.
Yeah. So psychological factors can be many. So beyond your standard outcome measures, which you can apply in clinical practice, things like TAMPA, short form of REBRO is a great one to measure a range of different things and different self-efficacy scales. But sometimes just asking the patient in front of you some really simple questions. So of course, picking up things like anxiety and depression and identifying need to refer for those types of things to psychologists is really important. I guess a lot of the psychological variables that as a physiotherapist, we have the opportunity to address are things like fear of movement, catastrophizing, those types of things. So asking simple questions like, are you worried you're going to damage your knee during this particular activity? Are you worried that your knee feels unstable during this particular activity? Just asking simple questions like that. And if the answer comes back as, yeah, I am worried I'm going to damage my knee with running or jumping or whatever it might be, or on the stairs. I think the next step from there as a clinician to assess is then what's driving that belief or that psychological factor. And it can be education they've received in the past and their beliefs. Sometimes it can be physical as well. So what we then need to do is make sure we tease out those things. So if someone's having trouble running or landing or doing those, or stairs even, those types of activities, certainly doing some physical assessments around strength and muscle capacity is really important. And if you're picking up key deficits there, then they should be things that are addressed through exercise therapy. And I think most physios are pretty comfortable and confident with doing that side of things. But then there's the belief side. And so understanding where those beliefs come from are really important. And a lot of patients I see in my clinical practice, those beliefs have actually been driven by media and or other health professionals they're consulted with. So every week I see a person who used to be a runner, who isn't a runner anymore because they've been told not to run anymore because they're going to damage their knee. So then understanding those beliefs a bit further, and they might have been told by a surgeon or a GP, then asking them, well, do you actually believe that or are you just following it? And if they do believe it, why they believe it? And then they may share information with you about being fearful of their imaging, and so reassuring about the lack of relationship between what we see on an image and what we see in terms of pain and disability. Looking at those types of things is really important. And then educating them that actually exercise is really important for joint health, those types of things. And then we need to couple that with an active approach to our education too. And so this is one of the challenges we have with education, is providing education shouldn't just stop at information delivery. And I think this is what a lot of people perceive. And so I always grapple with this in my head, is then if we provide education, we have to actively facilitate that to happen, which often involves exercise therapy. So it's really hard to disentangle those two things. So giving them an exercise that reinforces that education, for example, your knee isn't going to blow up if you go for a run. So why don't we just start it doing a couple of minutes of running as part of your 30-minute walk you've been doing every day? And so getting them through that, and then they learn that. And so that in itself is an assessment, because then you're measuring that change in their psychology as you go along, because they're able to do it. They're feeling more motivated. They've got better self-efficacy to do it along the way. So I think that's really important to get a good handle on. So I think if you break it down really simply, if we've got psychological factors, I think split them into two. You've got things like anxiety and depression, more clinical diagnosis of psychological factors, and they probably need other intervention or other health professionals. And then we've got things that are probably barriers to participation or engagement in exercise and physical activity. And they're things like fear of pain, fear of damage, catastrophizing, and they're things that we can then try and understand the beliefs of or the physical factors, and we have the skills hopefully to educate and provide exercise therapy to address them.
Fantastic answer. Christian, you mentioned a little bit earlier that with respect to fear of movement, that there can be a difference between performance and between just general day-to-day movement. Would you like to elaborate on that a little bit more?
Yeah, so I think it's a really good question. So if we talk about fear of movement, again, going back to the assessment question as well, one of the things, if someone has really high fear of movement, high fear of damage, I always like to put a step in front of them, and often a low step. So I'm talking a book, just put that in front of them, just a thin book, and you ask them to step up onto that step or step down off the step. And if their pain is really driven by fear of movement with those types of activities, their knee will hurt during that simple activity, and they're really not bending their knee any more than they might be during other activities through the day which don't hurt. So there's a lot of psychological involvement with that. And so the best way to address that is to tackle that and actually have a graded exposure to that exercise. As we know from Danilo's research, looking at strength and fear of movement, if we look at activity like stairs, their biomechanics are going to be influenced by fear of movement, but not so much strength because it's a lower level activity. So tackling that through a graded exposure type exercise is really important. Now, if you've got someone who's got fear of pain and damage with running and landing and those types of activities, if we force someone to do a high level activity and they're landing really stiff, for example, so they're not bending their knee very much, we can then have a look at that, and that's more likely to be influenced by physical capacity, so their ability to perform that task. So certainly we want to address those belief systems, but we then also need to take a step back and go, well, why is that person landing with a stiff knee? And so based on some other research we've been involved with looking at this, is that things like muscle strength and rate of force development will impact on how someone moves as we get to higher functioning tasks. And so then assessing and addressing those starts to become really important. And based on some of the work that Danilo's led as well, we can see, and be involved with other students that we've worked on, we can see that if we look at things like fear of movement, very, very well related to pain and disability, strength, not so much. But when we start to look at activities like how far can someone hop, how do they land, then certainly fear of movement can relate to those. But actually what often starts to relate a lot stronger is things like muscle strength and rate of force development of our quadriceps, of our hamstrings, those types of things. So that's where I think people saying, oh, it doesn't matter about strength exercise or addressing muscle power in this population because it doesn't have a strong relationship with pain and disability, so therefore don't stress too much about that. A lot of these people are trying to go back to sport and trying to be active and trying to do things, or they might be high risk of falls in an older population with patellofemoral OA, and those muscle capacity measures really matter for objectively measured function. So I think that's really important. The other thing to highlight as well is that there's a really poor relationship between someone's perceived ability to perform tasks and their actual objectively measured ability to perform those tasks as well. So when we look at these things, there's really big differences between that as well.
Mm-hmm. Thank you for that answer. Danilo, having completed your master's or I should say your master's in biomechanics, your PhD in psychological factors of patellofemoral pain, what do you think is next for this research area, and what's next for you in your own personal research?
I think we just need to understand better those links because most of the studies we did were from pilot and feasibility studies. So we need to try to test that in a larger scale and then implement that. That is a different question. So I would say that is what we need. So we are working on that and applying to get funding to support this research, to really confirm and guide what we can do and improve what we can do. So I think the next step is that to do larger studies and implement all of these that we have been looking at. And particularly, I've been looking at the impact of overweight and obesity in people with patellofemoral pain. And I'm really keen to explore that deeper. So that is probably what is next to me in the PFP field.
Awesome.
Can I build on a question from that? Because I think it's a really important topic to touch on, Danilo, in this space. And of course, your work focused a lot on education and exercise therapy, and you've just sort of mentioned overweight. How do you think that influences the condition? I know you've been working with some other students since your PhD. So how do you think that actually influences the condition of patellofemoral pain, and how might we target and address that?
I think there are not only one way that overweight and obesity are influencing patellofemoral pain. One obvious way that we think is mechanically, so overloading the patellofemoral joint. The heavier you are, the more load you have on your patellofemoral joint. But also things like inflammation and generated by the body fat tissue. So we have some data showing that people that are overweight, they are weaker and have poor performance compared to people that are not overweight. And also they have higher pain sensitivity generated by this inflammation that is going on because of the higher body fat they have. So we need to try some weight loss strategy, thinking about the load, but we also need to think about diet and what they are eating to try to reduce this inflammatory process that is going on the body.
And if we bring that full circle, Danilo, do you think that there are any psychological factors that might be involved in people who are overweight or obese in how they perceive their own pain or the way that they move?
Oh, absolutely. And we have under review data on that. So watch this space.
Oh, good. Oh, really, really great to hear. Danilo, Christian, it's been an absolute pleasure to learn more about your research. Is there anything you'd like to add or resources that you'd like to direct people towards before we finish this episode of Ask the Doctor?
I think Christian, alongside Michael Ratliff from Denmark, they were the founders of TRACK. That stands for Translating Research Evidence Knowledge. So we are building lots of resources on that. And we have a social media account on Twitter and Instagram. So follow us there. And we are working really hard to produce a range of resources for clinicians on telehealth, patellar tendinopathy, patellofemoral pain, knee osteoarthritis. So just follow us there, that we will make all those resources available for clinicians and patients.
I think the two key websites that kind of fit with what we're discussing today is and Danilo's led the development of both. One is patellofemoral.trekeducation.org, which is targeted towards clinicians, and the other is mykneecap.trekeducation.org, which is targeted more to patients. And my other recommendation for people is, not enough people follow Danilo on Twitter. So if you're watching this video, please follow Danilo on Twitter and you'll learn plenty from him.
I agree. Everyone needs to follow Danilo on Twitter and get around his 2-minute papers, which are just absolutely fantastic.
Agree.
Guys, thanks again. And I cannot wait to hear what's next in your clinical and research careers.
Thank you very much for having us, Matt.
Thanks for having us, Matt.